I get the privilege of introducing the first speaker, Dr. John Buse. Dr. Buse is the Verne S. Cavanis Distinguished Professor, Chief of the Division of Endocrinology, Director of the Diabetes Center, Director of the NC Translational and Clinical Sciences Institute, and Senior Associate Dean for Clinical Research at the University of North Carolina, School of Medicine in Chapel Hill, North Carolina. Dr. Buse completed service as President for Medicine and Science at the American Diabetes Association in 2008 and as Chair of the National Diabetes Education Program in 2014. He's received numerous awards and honors and authored more than 400 publications. The title of his presentation today is Personalizing Diabetes Care in 2021, and his talk is pre-recorded, but Dr. Buse will be here for question and answer if time, and then for the panel discussion at the end of today's session.
Hello, I'm John Buse from the University of North Carolina, and it's a pleasure to talk to you about personalizing diabetes management. Here are my disclosures. So what I want to talk to you today about is about the opportunities of personalizing type 2 diabetes treatment. And I think most of the conference is going to talk about personalizing as in to design or produce to meet someone's individual requirements, let's say as determined by omics. But there's also the form of personalized, which means to cause to become concerned with personalities or feelings rather than with general or abstract matters. And it's this second form of personalizing that I think is often forgotten and where I want to focus at least the second half of the talk of. And where are the opportunities? I think, first of all, early diagnosis of type 2 diabetes to ensure treatment improves long-term outcomes and creates the opportunity for prevention of type 2 diabetes if recognized in the prediabetes phase, but certainly the prevention of complications. Secondly, the treatment of type 2 diabetes is inherently complex in that it involves focusing on multiple targets at the same time, improving glycemic control, cardiovascular risk factor management, and weight really being essential for long-term outcomes. The aim is to prevent complications, enhance longevity, but equally important and often more important to patients is enhancing their quality of life today and in the weeks and months to come, not just focus on the long term. Third, we have a wide range of effective treatments in type 2 diabetes, each with distinct clinical characteristics with regards to efficacy and safety and side effects, and those factors are really important to patients. Navigating the treatment decisions to meet patients' individual needs change over the course of diabetes and can be very challenging for healthcare providers. And finally, and most importantly, I think it is effective communication between patients and their healthcare team is really crucial to improving patient-centered management and this concept of personalizing diabetes care. So here's some data from a couple of years ago that I think really makes the point very strongly that early glycemic control matters. But it's a kind of complicated figure. So I would just point out that as you go from bottom to top, you're looking at different periods of early exposure, either 1 year at the bottom or up to 7 years at the top. And the blue, black, and gray figures relate to different levels of hemoglobin A1C. So the light blue is patients with a hemoglobin A1C of 6.5 to less than 7%. The light gray diamonds are patients that have A1Cs above 9%. And then we're looking at microvascular, macrovascular, and mortality as complications. And what you can clearly see is that as you go to longer periods of exposure to hemoglobin A1Cs above 6.5%, and particularly as you go to long exposures with high hemoglobin A1Cs, that's when you see a higher and higher risk of microvascular and macrovascular complications and mortality. But the way it's really summarized is that for hemoglobin A1Cs greater than or equal to 6.5%, even in the first year are associated with worse outcomes, and that immediate treatment in newly diagnosed patients is necessary to optimize long-term risk of complications and mortality. A second version of that sort of most immediate message is the one that diabetes care is really about the long haul. And this is data from type 1 diabetes patients. They have a sort of more pure glycemic abnormality. And these patients were all followed by for 20 to 25 years. On the left, you see retinopathy outcomes. On the right, nephropathy. The black line going across is the hemoglobin A1C of 7% level. And what you see is that in general, the patients who have no complications tend to have A1Cs around or close to 7%. And those that have complications tend to have higher A1Cs. Well, we all knew that. I think this is a little bit different way of looking at things. And here, what's being shown is the prevalence of complications on the left, laser treated proliferative retinopathy on the right, persistent macroalbuminuria. And what you see is that for patients who have an A1C between 6 or less than 7.6 over 20 to 25 years, sub, sort of end stage or advanced diabetes complications are very rare. Um, and so the point from this really is early is a real opportunity in management, but it's really the long haul in achieving reasonable glycemic control in the long haul is critical for avoiding disability related to diabetes. The second axis that is complicated in diabetes, in type 2 diabetes, is that there are multiple pathophysiologic mechanisms, and in individual patients can have very or more profound defects in one area than another, and that does create opportunities for targeting therapies based on glycemic phenotypes that can be described, but also creates opportunity with regards to drug therapies. The issue is that the pathophysiology changes over time. In general, patients become more insulin deficient. They may have diminished incretin effects. In general, the hepatic glucose overproduction becomes an increasing issue, and the treatments often need to be modified over time. So we can't be static in the way that we think about individual patients and the therapy that they need. Diabetes is a dynamic disease, and therefore the treatment needs to be dynamic. And lastly, though we tend to assign particular drug classes to address particular pathophysiologic mechanisms, the truth is that these mechanisms pretty uniformly exist in virtually all patients, and these drugs work quite well in many. Is there an ideal drug to be selected in an individual patient based on individual characteristics? Sometimes. But if you look at the guidelines as they exist now from the American Diabetes Association and the European Association for the Study of Diabetes, the most important question that they suggest gets asked is, does a patient exhibit high risk characteristics, or do they have established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure? If they do, the preferred treatments are GLP-1 receptor agonists or SGLT2 inhibitors. And if they don't, the critical question is there a need to minimize hypoglycemia or to minimize weight gain or promote weight loss? Or is cost a major issue? At least in this way of thinking about things, these are really more patient judgments and issues for discussion between patients and providers. Functionally, the American Diabetes Association is advocating for personalizing diabetes care based on compelling patient characteristics and patient preferences. The last thing that I want to touch on is communication. And this blog was published in 2013. I must have shown this slide 100 times since then. And Dr. Ted Kapchuk of Harvard makes a point about the everything else in medical care. And what he says is he describes placebos as not just the traditional sugar pill, but also everything that surrounds a medical treatment, how caregivers describe the medication, how they administer it, the expectations that they have for the medicine, their tone of voice, the strength of their eye contact. In short, everything that doctors and nurses do in an interaction with a patient. He goes on to point out that shamans have known this since the dawn of time, but even now that we have really good therapies and interventions, the way we present it to patients and the nature of our relationship with the patient is equally as important as these very powerful treatments. This kind of concept is expressed here in a different way, where Mark Payro did interviews of patients, got them to characterize the relationship they had with their providers, and then correlated it with diabetes control, adherence to medications, and diabetes distress. And very profoundly, patients that characterize their relationship with their provider as good, in general, had better control, better adherence, and less distress. So the ADA and the European Association for the Study of Diabetes have embraced this idea of the empathic patient-centered care that really to determine what is the best management option for each patient, we need to be aware of their personal, social, and biomedical context, their values, how he or she values the available options, and the relative contribution of each option in terms of benefits, harms, costs, and inconveniences. And that this is really the critical piece of the patient provider interaction. And that the path to successful management is driven by shared decision making between patients and providers, the provision of diabetes self management, education, and support, a process of continuous reassessment with the patient on how they feel about their medications and the responses that they're having, with really a focus on adherence and persistence, and avoiding clinical inertia or avoiding deferral of treatment decisions to a later date, at least as possible. And to that end, Anna Kokoska, now a young faculty member at the University of North Carolina, pointed out to me and engaged some folks from Novo Nordisk and around the country to think about the issue of how we present clinical data in publications. And for instance, in the package inserts of drugs, where we look at the average response of the average patient. So on table one, we describe the average patient with regards to median age, the proportion that are males, the median BMI, et cetera, et cetera. In the figures and tables at the end, we look at the median A1C response, the median weight response, but we should do this in a better way. And here she described a tool that still is under development, where the tool will predict for an individual based on their individual patient characteristics, their age, their hemoglobin A1C, their BMI, their gender, how long they've had diabetes, what their current diabetes management program is, and what is their level of renal function. What would be the expected A1C lowering of a class of drugs? What would be the expected change in body weight for a class of drugs for that individual patient with those characteristics? We hope to be able to build this out better as a tool to enhance communication, but at the end of the day, I do think that the patient preferences are very important and they just take time to get into the open. So to summarize, early diagnosis and treatment is a unique opportunity with lifelong impact on outcomes. Therapeutic inertia, medication persistence, and adherence are the critical barriers to optimal outcomes. Improving lifestyle is the essential element of all management approaches and requires consistent personalized coaching. But it's really empathetic, patient-centered, shared decision-making and support that are the most critical elements. Functionally personalized diabetes care. And this comes from a perspective of ensuring that you teach and do not preach, and that you motivate and do not castigate. It is the everything else of medicine that's essential and the essence of personalized diabetes. And I'll just leave you with this image of of thinking about the patient healthcare provider dialogue. It has to be open and based on trust and respect. It has to be associated with realistic expectation, effective support and motivation, understanding barriers and opportunities, and providing for patient engagement. So functionally, the personalizing of diabetes care. Thank you very much.
Thank you, Dr. Buse, for that great presentation.